Evening, everyone. Welcome to this evening's webinar on reverse total shoulder replacement by Professor Imam. I'm sure it's going to be a very good topic for us all to learn about, and it'll be really important for your FRCS exams. So the order of this evening is that we've started slightly earlier, and we're going to finish at 7:30. So this evening, we probably won't get around to doing any vivas, but we're going to have a very interesting talk followed by some questions from the audience, and we'll try and answer what we can. If anybody misses the recording or part of it, then it will be available on our YouTube channel in a couple of days. So don't panic, you can watch it again. So what I'll do is I'll hand over to Professor Imam for the lecture. Thank you very much.
Thank you very much, Nikki, and thank you everyone for attending. It's a pleasure to be here, and it's really impressive what the FRCS mentor have provided for thousands and thousands of orthopedic surgeons globally. Today, I'm going to talk, I can talk about reverse shoulder replacements for a few hours, but, we'll try to summarize it into 40 minutes. I'm going to talk about concepts, innovations, history, biomechanics, and complications of reverse shoulder replacement. It's a very important topic. I was asked that topic in my exam many years ago. It's now becoming very common, and complications also has become common because complications have become common as well because of what we've been doing, because we are doing more and more of these. So reverse, in this talk, what I'm planning to do is actually few answers. What do we need to know? What is the evidence, concepts, indications, complications, technical problems? I had actually, maybe in the next talk, we can talk about prevention of complications and so, but that might be not suitable at this point. We all are seeing a lot of reverses in all our hospitals. It became a common procedure done everywhere. And what really matters to hospitals is different. What really matters to managers, to consultants, to registrars, to companies trying to selling their implants. And what we'll try to focus today on what actually is needed for your exam, for the FRCS exam or any exit exam. There are stuff that we're going to go through that might be beyond the scope of the exam, but it's good to know you can skip it if you're not interested into that. A key concept, what's really important for the exam is to understand the biomechanics of shoulder replacement. It's actually, there is a paper by Matsen et al. About the biomechanics of shoulder replacement. It's describing it in the pillar pole concept, which has been highlighting important aspects that we all should be thinking of while talking about this. So a key concept describing the mechanics of the normal shoulder is the concavity compression concept. So in general, Matsen et al. Describes this concept as a ball sitting in the concavity of a table. So the greater the depth, the concavity, the greater a displacing force must be to dislodge that ball for a given compressive load. So in the normal shoulder, the rotator cuff muscles provide the compressive load. I'll show you a picture later. And this is lost in rotator cuff deficient shoulders, leading to instability because there is unbalanced muscle forces in the glenohumeral joint. Another important aspect here also, which we have to understand fully, is in the normal, which also was highlighted by Matsen and Leppett, is the concept of the glenoid center line. So in a normal glenoid, the center line, as you can see in this picture, represents a line perpendicular to the articular surface of the glenoid and directed on average approximately 10 degrees posterior, so retroversion, to the plane of the scapula, like what you can see in A and B. So this center actually serves, this center line serves as the pillar under which the humeral head rests. So glenohumeral and scapulothoracic motion are coupled to maintain the center line beneath the humeral head throughout the full range of motion. However, in rotator cuff deficient shoulders, these unbalanced muscular forces we mentioned earlier disrupt this relationship, and the mechanical alteration can lead to pathologic wear patterns on the glenoids. That's why you keep hearing shoulder surgeons talking about superior, inferior, anterior, posterior, all global wear. So when you're doing a shoulder replacement, the glenoid component should be placed along the glenoid center line. However, in some cases with glenoid bone loss, this component, the component placement in this plan is almost impossible. So in these cases, a stable base plate fixation can only be achieved by placing the component along the alternate glenoid center, as you can see. Another important aspect as well, which describes this problem, is actually looking at normal shoulder biomechanics. So if you see here in a cuff deficient shoulder, there is the concept of impingement because the humeral head has displaced superiorly. And so you have what we call acetabularization. So the greater tuberosity and the acromion impinge together and lead to acromial erosion or acetabularization. So in patients who have lost the dynamic stabilizers of the rotator cuff muscle, the humeral head migrates superiorly and leads to abutment underneath the acromion. In these cases, using a fixed fulcrum prosthesis like a reverse shoulder replacement is the only option and can neutralize the dynamic instability. So because of because of the proximal migration here. So with rotator cuff arthroplasty, the most well-known classification, that if you want to cite a classification in the exam, is the Hamada classification. And Hamada classification is straightforward and easy. So it looks at the acromial head distance in grades 1 and 2, 6 millimeter above and 6 millimeter below, makes grade 1 and 2. If you have acetabularization, that's grade 3. If you have narrowing of the glenohumeral joint, as you can see, that's grade 4. And there are 2 forms of grade 4A and 4B. And when you have collapse, it will be grade 5. So if you want to cite evidence in the exam while having a case of rotator cuff arthroplasty, I think that's an easy classification to use if you want to. So what happened here? You know, these patients are now more common. We see them all the time. This is a classic picture of rotator cuff arthroplasty. You can see the stabilization, femoralization, disruption of what is similar to the shinton line in the hips. And this patient obviously will have pseudoparalysis and marked limitation in movement. What we should understand in this diagram, which is really an important diagram, the wide spectrum of disease that can be seen in rotator cuff arthroplasty, ranging from stability to instability to arthritis, and that happens over time. So when you see these patients, it's really crucial. If you're seeing someone in a viva situation or in a clinical situation, it's important to demonstrate your your thought process. So, but before we go into that, I'm going to briefly discuss the history of reverse shoulder replacement. So actually the first one who introduced such implants is Charles Neer. However, the problem he had is that in these patients where there is deficient cuffs, there was high failure rate because the cuff was deficient. When the Neer prosthesis was used in patients with proper intact functional cuff, he had good outcomes. And what happened, and then things developed over the years, and surgeons started to realize the main aspect here is to achieve a stable center of rotation, and that has developed over the years, as you can see in this video. Actually, the first shoulder arthroplasty, interestingly, was performed in 1893 by a French surgeon. all surgeons and over the years, surgeons were thinking of different concepts similar to the reverse shoulder replacement. They were looking at, of course, learning from the most successful replacement we had, which is the hip replacement, and trying to reproduce that. But the main problem of all these replacements, you can see interesting pictures here. The main aim of all these replacements at that time was to have a stabilized center of rotation, but all failed because of the excessive torque and shear forces of the glenoid component bone interface. It was up till the man no one has made a huge difference in shoulder surgery as much as Gramont. So Professor Paul-Marie Gramont directed two engineers in a study in aiming at achieving the stabilized center of rotation. He aimed for medialized center of rotation, distalization of the humerus, so that ultimately will decrease the shear forces on the glenoid component bone interface, improving the lever arm of the deltoid, putting the deltoid at a superior biomechanical position in order to be able to move the shoulder without the need of intact cuff tendons. That was the first components by Gramont, and this components has and if you can look here, all the principles Gramont was aiming at by medializing the center of rotation, so that increasing the lever arm. If you look at this diagram, you can see this is the center of rotation here. The deltoid cannot function in that position, but when you medialize the center of rotation and distalize the center of rotation, you improve the lever arm of the glenoid. Theoretically, he aimed at the problem we had with the previous designs is you increase the shear forces at the glenoid base plate, but by medializing the center of rotation, things has been better, and that was in 1984. And so if you want to do a lever, if you want to do a diagram expliciting this, you can find that very clear here. Now we are actually doing more and more reverse shoulder replacements. The main indication is still cuff arthroplasty, but we can do it for irreparable cuff repairs, complex humeral fractures, inflammatory arthritis, failed arthroplasty, tumor surgery. It is the main revision option for any most failed proximal humeral surgeries. So these are what we see in patients with rotator cuff arthroplasty. You can see the femoralization here. You can see the stabilization of the acromion in this classic presentation to one of the patients. So it is used for fractures. And there are a lot of evidence supporting the use of reverse shoulder replacement. We looked at reverse shoulder replacement for younger than 60 years old as a revision processes, which is a paper from Zurich. I was contributing to that one. And we found that actually, that's what have driven some surgeons now for doing primary reverses, as you can see in a lot of places you're working in, because of the increased complication rate in young patients with failed proximal fixation. You can see drastic pictures and big failures there. So what are the contraindications? These are the general contraindications for reverse shoulder replacement. The two absolute contraindications here would be deltoid deficiency and active infection. I would say active infection is the main one, because with deltoid deficiency, there are surgeons doing tendon transfers and other associated, simultaneous procedures in order to overcome the deltoid deficiency in cases with for undertaking a reverse shoulder replacement. So in the exam, always be systematic, history. It's all about clinical suspicion, asking about absolute contraindication, the likely concept of diagnostic clusters as proposed by the upper limb unit in Wrightington, probable diagnosis. You have to include history, examination, investigation, and special tests. With imaging, it's crucial to understand the pathology. It's really important to what we tend to do for all of them is CT scan. I do that. I tend to actually, we have to, with CT scan, I'm looking at the bone stock. That's what you should highlight. We're looking at the version and we are looking at the bone loss, because that dictates your treatment, because you should be fully ready for these patients. This is a technique which is, we proved it is more accurate in defining the glenoid version. And it's crucial to understand what type of glenoid, and that's what you show in your exam if you are discussing in details. And of course, MRI not usually needed unless there is an indication for that. Nowadays, we have pre-operative planning options, which enables us to understand where to put our component. So we have a lot of tricks and that would help, but this wouldn't be, you might not need that for the exam. So which approach to use? It's really important to understand which approach to use. If you ask me what is the approach I'm likely going to be asked in an FRCS exam, it's possibly the deltopectoral approach. And this is my preferred approach. You can be at the fully dedicated surgeon just doing the deltopectoral approach. It is a versatile approach which you can extend. And actually what I would like to highlight to all of you here, whenever you're describing approaches, this is the deltopectoral. I'm not going to go through different bits of the deltopectoral approach, but try to speak as if you yourself have done the operation before. Try not to say what you've seen in the books. Imagine you are telling a story or describing an approach to someone over the phone. I'll use phrases like, I center my deltopectoral approach incision on the deltopectoral fascia. I'll do my approach slightly lateral to the coracoid because there is evidence that this will enable me to have better access to the glenoid. I often release the bursa underneath the deltoid muscle, identify the cephalic vein. So if you keep telling this story all the time, you will make the examiner entertained, while giving also the bits in between. Your description of every surgical approach should begin with a brief gambit on preparing the patient for surgery, like, having prepared and consented the patient for the theater, I will do so and so. It sounds better to phrase it like that than go through every preoperative step verbatim like that. If the examiner wants to probe you on this, he or she will otherwise need to offer it up to you. So you must not forget to mention this. What's really crucial now, a technical part, as you can see in that video, it's really important here to release the subscap. If you're describing the deltopectoral approach for a case of fracture, you don't do subscapularis tenotomy. You actually can go through the tuberosity, the fracture, because there is no need to do the tenotomy. And actually in the exam, you might miss that, but it will make you look better and look more succinct and actually look more experienced while describing it that way. And you can always mention landmarks and how to avoid critical steps and there are technical bits. So if you see someone with a fracture, 4-part fracture in the trauma situation, and you want to operate, do a reverse shoulder replacement, you can describe, or I will position the patient on beach chair, I'll take x-rays before I put on the drapes. These are the things that would make you stand proud among your peers, which is actually what you should be aiming for. If you know something well, you should be aiming to achieve as much as you want. Here you can see the release of the labrum, and that's actually the delivery of the head. With reverse shoulder replacement, it's always For fractures, it's always important to preserve the tuberosities. This is a very good exposure, and this is the long head of biceps. But for exam purposes, I don't think you will need to go that far. So what I would, and this is all, of course, preparing the glenoid. So what happened over the years? Since the Gramont design, although we said it is a more stabilized center of rotation, this was associated with problems. This includes the notching, rotation, instability, and limb lengthening. And notching has always been a problem with reverses, and we're going to discuss it in details. Instability has been reported to be as high as 30% in the Gramont earlier designs. Arm lengthening because of medializing and distalizing the components have also been a problem. And then Frankel, surgeon in the US, has popularized the concept of lateralization. This might be beyond the exam, but it's good to know. So lateralization now, we try to achieve, you can achieve lateralization either through on the glenoid side or the humeral side. And for both, you can either do it using bone graft or metallic graft. As you can see, this is BioRSA on the left side. So glenoid lateralization can be achieved through few things, by reducing the neck shaft angle, by using a curved stem and eccentric tray. This will enable you to achieve humeral lateralization. Glenoid lateralization, either BioRSA or the biologic type or the metallic type. So we have different options, different components. What do you do for each of these? Actually, more and more components are there now, but we have to understand the science behind each of these and what you expect to achieve behind glenoid and humeral lateralization. As for anything else, there is no right answer. There is wrong answers. But the advantage of lateralization through the glenoid is that you can have less notching, you can achieve better rotation, you can achieve better shoulder contour and less instability, but you will have reduced abduction and there is increased risk of glenoid loosening. The advantage of going on the humeral side is actually you are going to achieve better rotation, still less lengthening on the arm, less notching, better shoulder contour, while the disadvantages, this is also associated with reduced abduction. So having the medialized center of rotation will enable you to have better abduction. So what do we do? So now we're going to the next few minutes, I'm going to go through complications. I think there is an option now, especially with more and more shoulder replacement we're doing. You might have a scenario with a shoulder with a reverse complication or not, but we'll go through it quickly. Complications initially reported to be high, and here it was mentioned that it is as high as 15% in this paper. However, looking in depth on that publication published in 2006, 3/4 of these 7,000 total shoulders were performed annually by surgeons who would do 2 or less a year. So actually, that's a huge limitation. And now we think we're achieving better outcomes and less complication rates. There are complications for all types of shoulder arthroplasty, and there will be specific complications for each of the main shoulder arthroplasties we use. All of them will have the common complications of infection, hematoma, loosening deltoid dysfunction, instability, fracture, nerve injury, and all these. But for anatomic and hemis, the main complications that you should warn your patients and you as a surgeon should be aware is rotator cuff dysfunction and, of course, glenoid loosening in anatomic shoulder replacements. Now there is an increased consensus of just doing a reverse for someone above the age of 75, because we know that the risk of the cuff being dysfunctional is high. And so if you do an anatomic shoulder replacement for someone where you can see an intact cuff, doesn't mean that the cuff is fully functional, and also there is risk that it will fail in a year, 2 or 3 years time. So why not go with a reverse immediately? For hemi, it is, of course, we tend not to do hemis more now. But unless, of course, younger patients, there is other options like biocarbon heads and stuff like that that can help decrease the hemispecific complication of glenoid erosion. For reverses, I'm going to go through the complications and tips and tricks in order to avoid them, which we'll go through them quickly for the purpose of the exam. Notching, we looked at 159 patients. We found these are the complications in these multi-center trials. And of course, the main complication all of us would be worried about is infection. And having a scenario with an infected shoulder replacement is also something that you should be ready for. We know from evidence by Professor Gerber that primary anatomic have 1% infection rate, while reverse has 5% infection rate. You know, a good question you should be asking yourself now is why reverses has a more complication infection rates. Many reasons for that, possibly because these are older patients, they have large dead space, there is absence of living soft tissue cover such as the rotator cuff, and another thing that was found in previous evidence is that multiple previous surgeries has been a risk factor for having an infection in any joint replacement, and the chances of you having multiple surgeries before a reverse shoulder replacement is really high. These are the commonest organisms. P-acnes stay exclusive for shoulders. The tricky part of diagnosis and infection in a shoulder replacement is this paper in 2006. And I remember every time I see someone with a shoulder replacement that appears to be infected, and I'm worried about infection here, which is basically they have normal CRP in 75%, they can have normal ESR in 86%, normal white cell count in 93%, while having an active infection going there. So it is a clinical diagnosis with high suspicion, and that's something you should always bear in mind whenever you are facing with one of these patients. And this is strong evidence to cite in the exam. So what type of infection is there? For acute infections, we can manage them by antibiotic. If you have infection, if you're doing a revision and there is infection there while you're doing a shoulder replacement, you can do organism-specific antibiotics and close clinical observation. If you have it in the first 30 days, we can still do the DARE approach by prosthetic retention, just changing of the insert. If it is more than 30 days, you can still manage it as type 2, or you can manage it as a 2-stage revision. If it is type 4 chronic infection, more than a year, then 2-stage revision. We looked at this at the outcomes of 48 patients with periprosthetic infections during my fellowship with Christian Gerber. And we found that using antibiotic-loaded cement spacer provided successful infection rate in patients with this in 90% of the time. And that has been now the most common approach of managing these. For the functional improvement after doing a second stage using a reverse shoulder replacement has been observed, and it is significantly higher than that after hemi or a cement spacer used definitively. So what about notching? What is notching? I know all of you, if you're not doing a lot of shoulders, you hear the word notching all the time. Notching is actually a mechanical impingement between the supromedial aspect of the poly insert in the humeral side with the inferior scapular neck. You can see it better in this cadaveric video. So that's where notching is happening. So why notching is a big thing, and we keep mentioning it in all arthroplasties of in all reverse shoulder replacement. It has been popularized and picked up by Servo in 2004. And Grading they proposed is pretty easy. So you have notching. Grade 1 is here. Grade 2 is actually when the notching is in contact with the lower screw. Grade 3 is above the lower screw, and grade 4 is under base plate. And obviously in grade 4 there is the risk of marked base plate loosening. So it has been observed in Grammont type to be as common as 88%. In our study, we found it to be at 35% in a more lateralized stem. Does it make a difference? In our study, we didn't find any difference in clinical scores or range of motion exercise or range of motion. However, in others, they found that it continues to worsen and there is negative outcomes. And you can see that notching has been observed to progress over the years, and it has and looking at the clinical evidence, it is actually debatable. So some mentioned there is no influence, others mentioned there is negative influence on long term. So does it affect the outcome of shoulder replacements? The answer is we're not sure. So we need, as anything else, more research, but how can we prevent notching? I'll go through that quickly. One thing you can do to prevent notching is when you're positioning your sphere, you should position it a bit inferior, because that will result in a less mechanical impingement between the supromedial aspect of the base plate with the inferior bit of the scapula, and that will increase the arc of movement. So that's also something we tend to do all the time now. Another thing I tend to do, which is recommended, is instead of putting your base plate like that, you do a bit of inferior tilt, and that will prevent notching further. Avoid excessive reaming because you are over medializing the glenoid. And finally, implant choice. We have different options like using bone graft or using metal cups. The other things that you can use actually is use the lateralized center of rotation. You can increase the size of the gleam sphere. You can decrease the neck shaft angle when you're doing the procedure. You can see here when you use a lower neck shaft angle like 145, you're actually increasing the range of motion as per the study. You can always decrease the cup depth because also that will prevent notching. Use eccentric gleam spheres. Angled insert has been proposed by some. So including all these options all together can ultimately lead to decreased notching if you're really worried about it. And we actually are worried about it because think about it, if you keep having notching for long years, you know, the grading will increase up to, and that can ultimately lead to unstable base plate. So what about instability? Instability has been a big thing with the Grammont. It is common in anatomy shoulder replacement, but in reverses as well. It has been highlighted to be up to 30% in some reports, as I've mentioned earlier. And if you have someone with instability in the exam, like everything else, there are patient, surgical, and design-related factors. Patient-related factors, those who had multiple surgeries, the poor deltoid dysfunction, compliance of patients who are recurrent fallers, epileptics. Surgical-related factors is also an important aspect. We tend not to blame ourselves as surgeons, but approach has been mentioned to be causing that, but we'll go through that as well. If you have humeral discrepancy, malposition of the humeral components can cause that as well. Having a hematoma is a risk factor for instability as well. And of course, you have to maintain the deltoid tension. There are some reports saying that superlateral approach might be associated with less stability. Having said that, in deltopectoral approach, preservation of the subscap and having a superior approach as preservation of subscap can help. Although I think this approach is not really a great factor, as the deltopectoral is the main approach for many shoulder surgeons. Instability also, the surgical factors include humeral length discrepancies, as I've mentioned, and you can see that you can risk placing the humeral component too low. So if you have a humeral loss, bone loss, there is a high risk of having a dislocation there. And it's really important to understand these in fracture cases, which is somehow a bit more challenging, and the revision cases. Malpositioning of the components, all shoulder surgeons would aim for 0 to 20 degrees of retroversion when applying a shoulder replacement. The last of surgical factors here is preservation of the soft tissue envelope, which is a important surgical aspect in every surgery we do. Deltoid tension, you have to maintain deltoid tension, and that can be achieved by increased lateral offset. Design-related factors, as we've mentioned earlier, the designs can be associated with instability as well. So how do you manage instability? If you see someone who's coming to your clinic or in the exam with instability, you have to assess the nerves and muscles. It's crucial. You have to do CT scans to rule out structural abnormalities like a fracture, notching, base plate fixation failure, component malposition, and you have to exclude hematoma and infection. Prevention is crucial as well. We wrote about the lateral thrust and lateral thrust test. These are the tests I would use when I'm doing a reverse shoulder replacement to make sure we have a stable prosthesis in place. So if you're shown an X-ray of a dislocated shoulder, reverse shoulder replacement, I would opt for closed reduction under anesthesia and follow up by 6 weeks of immobilization. We have to investigate it further, and possibly you might have to exclude infection at all times. You have to identify from all the factors we've mentioned what might be the cause here. Before opting for revision surgery, you have to understand the reconstruction of soft tissue, humeral length discrepancy, and the version. And then if you have humeral length discrepancy and less than 2 centimeters, you can just increase the gleam sphere, as you can see in this picture, or you can use a bone graft if it is bigger. One important complication that has been cited a lot is base plate failures. It was very common before, but it's less common now with more modern designs. Common causes include poor initial fixation, osteolysis, and infection. Can take several forms, as you can see here: screw fracture, base plate failure with screw fracture, dissociation, as you can see, between the base plate and the glenoid hemisphere. And for each of these, you have to understand what's going on. You have to prevent it while doing it, and then it can be managed accordingly. But this has decreased significantly. I have a Holcomb has proposed that when you do the inferior tilt of the base plate, you achieve less glenoid failure and you achieve less notching. All modern designs now using blocking screws. That's why we're seeing less base plate failures. Of course, a single versus 2-stage revision based on the infection or not, and technical notes can be your management plan. What about periprosthetic fractures? It's becoming more and more common. The risk is cited to be as high as 2%. Now it's actually, I think periprosthetic fractures on humerus will be the new pandemic. We see weekly periprosthetic fractures in hips and knees. That's because we've done thousands and thousands of hips and knees. Now the fact that we're doing more shoulder replacements everywhere, we are going to see more and more of these. Wright and Caulfield in 1995 used a similar classification system to hips: type A, type B at the tip, and type C distal to the tip of the fracture. There is different ways of managing each. Most importantly, when you're doing a shoulder replacement, you have to avoid forceful external rotation, excessive reaming. I personally don't use a Tremano or Spider on any of the holding devices. You have to be extra cautious and careful. And there are also glenoid fractures. In our study looking at 5 years, we had few periprosthetic fracture on the humeral side. To prevent this sort of glenoid fractures, you have to start reaming beyond the subchondral bone and start the reaming before contact with the glenoid bones, what I would say, to prevent it. So what about you have different options. You can, if you have that during doing a shoulder replacement, what we tend to do, we use base plate screws to stabilize the fracture. You can use other screws to stabilize the fracture and then put your base plate on top. You can reorient the central plot into a more robust bone with especially with those with compression center screw. A port glenoid sphere implantation, insert hemi, revise to a reverse at a later date is another option. Deltoid dysfunction can happen, 0.1%, which is lucky, and this is a catastrophic complication if it happens. Hematoma formation, more common in reverse, as I said, because there is bigger space there in reverse. There is usually multiple procedures done before, and it is a problem with hematoma formation. It can ultimately lead to infection, and as I've shown you before, it's hard to diagnose infection in shoulders from clinical aspects. Last pair of complications here, thromboembolic complications, less than 1% for DVT, and PE is less than 0.5%. There is a lot of advances in shoulder replacement, and there is more to come, including virtual reality and machine intelligence. We have to, if you are having a reverse, if you're discussing reverse shoulder replacements, which is a common option now for rotator cuff arthroplasty, for fractures, and for different scenarios, it would be important. And actually, I was asked that in basic sciences clearly, what is a reverse shoulder replacement and how you do a reverse shoulder and about biomechanical aspects. It is important to understand all these for the purpose of the exam. Sorry for taking long. Remember, when you're discussing anything in the exam, your day one consultant, you don't do a procedure for the first time on the day. You say, if you have to discuss something you don't know, say the principles are 1, 2, 3. If your consultant do a weird procedure, having a graft for or doing microfracture or doing cord decompression for arthritis, all these procedures that's not written in the book, and there's no general consensus. No one actually cares what your boss does. There are a lot of common wrong answers, but there is no right one, and common is common here. If you're asked to discuss the reverse and you want to draw whenever you can draw, that will make your life easily. If you don't know, say I don't know, and thank you.
Thank you, Professor Imam. That was a very comprehensive lecture with lots and lots of top tips for your exam. I was asked about this in basic sciences as well. So make sure you're quite clear on why you do a reverse and the biomechanics of it and what happens when you lateralize it and things, all of that stuff. And drawing it is excellent. It just helps focus your mind, and the examiner can see that you know what you're talking about. And it also gives you that little second, if you have a bit of a brain freeze because of the exam, then getting your pencil and your bit of paper and starting to draw will help center your thoughts a lot as well.
Yes, I can't agree more. And actually, you avoid eye contact with the examiner because it is stressful as well. So, and you're not rude, so you're looking there, and you can use less words. It's a bit relaxing. I've always, in my exam, I've drew a lot of stuff, even if there isn't a proper drawing in my mind.
Great, thank you. Okay, so a question has popped up from Pangiotis Movridis, and he's put, why is abduction decreasing when we lateralize?
So if you lateralize, so abduction decrease because actually still with deltoid, with the medialized center of rotation, the deltoid is at a better functional position because you have the medialized center of rotation and you increase the lever arm of the deltoid, so you can have a better function. Having said that, even with lateralized components, you can still have good abduction. But if, generally speaking, you'll achieve more abduction with the medialized components rather than lateralized components.
Okay, I hope that answers your question. Are there any more questions? We're quite a small group, so if you do have one, you can raise your hand and you can ask Prof yourself if you want to. Anyone got any?
I have a question actually.
Okay.
So in case of trauma, Prof, if like a patient below 60 years and there is like a comminuted and proximal humerus fracture and you decided to do an arthroplasty, when you will do hemi and when you do reverse shoulder?
It's an excellent question, and the answer is actually dependent on the patients themselves and the type of the fracture. Because, you know, you can be committed with a reverse shoulder because, you know, it's not very helpful if someone is young and you do a hemi and, you know, you're not going to achieve significant range of motion. So if someone is 40 years old, it's unlikely I'll be doing a hemi arthroplasty. I'll be doing a reverse. I'll be opting more towards a hemi arthroplasty. But in the 50 to 60 age group, I know, and the evidence is quite clear in that regard, is that reverse is better than hemi arthroplasty in this group of patients. What the worst outcome you can achieve in these patients is actually opting for fixation, and you're knowing that fixation will definitely fail, and then revising it later on, as we've demonstrated in that study I've shown.
Thank you.
Thank you.
Okay, any final questions before we wrap up this meeting? Nope, can't see any hands raised. Okay.
Good.
All right, guys. So thank you very much, Prof. That was an excellent lecture. And yeah, I certainly, you know, learned a little bit from that. And yeah, you guys can all watch it again. It'll be available on the website, usually in a couple of days or so. Yeah, and share with your colleagues because it was excellent. And, you know, it's the kind of thing you get asked in the exam, and it's just been presented really concise and straightforward for you. And if you present it like that in the exam, they're going to go, oh, this guy knows what he's doing. So thank you, everybody. If I can ask all the candidates to leave, and the mentors will just stay for 5 minutes to do a debrief. And please join us next week for shoulder arthroplasty. Thank you very much.